Welcome to the podcast for Healing Neurology, where we talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine. And we are honestly blessed to have with us today Dawn Ipsen, who is a pharmacist. So technically Dr. Ipsen, but we're going to call her Dawn today. So good morning, Dawn.
Good morning. Thanks for having me on today.
It's so great to have you. I'm so excited to have this conversation. So you are the owner and the pharmacist at Clark's Compounding Pharmacy in Bellevue, Washington, and Kusler's Compounding Pharmacy in Snohomish, Washington. Dawn graduated from the University of Washington with a doctorate of pharmacy in 2001, where she received the Dean's Outstanding Service Award. She also holds memberships with the International Academy of Compounding Pharmacists and the Washington State Pharmacy Association. She's a clinical instructor for the University of Washington School of Pharmacy and an affiliate faculty member for Bastyr University. She is a pharmacist preceptor for Washington State and teaches Doctor of Pharmacy students. Dawn also serves on the Professional Compounding Centers of America, PCCA Advisory Council. She was actually named PCCA Pharmacist of the Month in 2016 and Washington State Distinguished Young Pharmacist of the Year in 2011. Dawn has presented on the topic of pharmaceutical compounding to physician, patient, and peer groups. She is dedicated to helping her community find solutions to medication problems through personalized medication therapies. And honestly, you and I have been working together for a number of years now, and I know that you are always a reliable source of fantastic information and really creative and brilliant combinations for medications. So we are so pleased to have you here today. Thanks for being with us.
Thanks so much for inviting me. Yeah, it's an absolute pleasure, and I've sure enjoyed our relationship. And you always propose the best questions. I love that sometimes they challenge me even, so that's fabulous.
Well, I think we underestimate pharmaceuticals for one. So pharmaceuticals we often think of as like late night TV advertisements, Tesla. But pharmacy, the practice of pharmacy, the science of pharmacy is actually millennia old and incredibly creative. So talk to us a little bit about what pharmaceuticals and pharmacy is.
I pretty much kind of do the really traditional, like the old school pharmacy, so to speak. So you're right. It's been around for centuries and way before drug companies ever were even a thing. And it was, you would go see the pharmacist and they would, put together various potions and liniments and tinctures for treatment. And then, over time, and that started kind of in Europe primarily. And then in the US, it transitioned this way as well, of course. And then we got, pharmaceutical companies. And so today, what most people think of pharmacy is they go to their local, corner drugstore and they walk in and they take this prescription to the pharmacist and they fill it and they count, lick, stick, and pour, as we always joke, and count by 5, throw in a bottle, put a sticker on it, and toss it across the counter to the patient. When I started pharmacy school, I tried that for the first year. I thought, okay, this is what pharmacists do. I'm going to go do the retail thing and I'm going to, fill these prescriptions. I'm going to make a difference. I'm going to really help patients. And I got pretty bored. And I'm not saying that retail pharmacy isn't great. And it's perfect for a lot of people. But for me personally, I had this really inquisitive entrepreneurial science brain that counting by 5 wasn't very fulfilling, and corporations were putting a lot of pressure on pharmacists for volume, and the care portion for me wasn't there. The creative portion for me wasn't there. And so actually as a pharmacy student, I had an opportunity to take an internship at an independently owned pharmacy in a community that also compounded. Life-changing experience for me because they treated their interns as the problem solvers. And so they were the ones who took every question from a doctor, had to figure out all the formulas, had to do the research, had to do the legwork to figure out how to solve a particular patient's medication problem. And I just fell in love. And it was, I felt like I was making a difference. I felt like I was really helping patients on an individual basis. I was getting to use my science brain and my creative aspect and also keep entrepreneurial things in mind too, because obviously if the pharmacy wasn't profitable, they weren't going to be there to help the community. So we had to keep that in mind also. So yeah, that's a little bit about how we got into that.
We're talking about like there's Bartell's and CVS and Walgreens and Safeway pharmacies. So there's all these pharmacies and those are fairly commercial. So they stock fairly usual, kind of common, and we call those typically commercial pharmaceuticals. And then we have independently owned pharmacies and then we have compounding pharmacies. So what the heck is a compounding pharmacy?
Yeah, so compounding is it's actually a verb. It's what we do. So you're right. There's the more traditional retail pharmacies that sell things made by manufacturers. We have Pfizer and Merck and all these big companies that they mass produce, typically very small, different tablet size of a particular medication, and that's all they do. And independent pharmacies, that's more of an ownership basis. Like they're independently owned, and they're the coolest type of pharmacy because they'll really do what their community needs. They will sell the traditional manufactured medications or dispense those, but then they'll often do these other niche programs. Like they might be, doing immunizations, they might be doing disease state management, they might be do compounding. And so I'm also an independently owned pharmacy. Both of mine are, which means that I myself own the pharmacies. But we do one very specific niche. We are a compounding only pharmacy. So that's our verb. That's what we do. And I used to, before I bought Kusler's, they call it a hybrid where you did all the different kinds of pharmacy, retail, and everything else. But when I became owner, we became compounding only. And actually, it was a very sort of scary venture to put all your eggs, so to speak, in one basket. But what we found super quick, almost day one, is we became even better at it because now our brains were fully focused on doing one type of pharmacy. And as pharmacists, we weren't switching gears with every single prescription, which is, often could be hundreds in a day to have to make sure we're doing the right process for that prescription. We just focused solely on that compound process, which was super cool. And has been, successful for us because there's such a need in our community for it.
Compounding, as we were joking before this started, is, you're not there in the back with a cauldron and a big wooden stick and an open fire. And so what is compounding? How do you do that? What does that entail?
It's extremely sophisticated, very, very high tech, and over the top regulated, which isn't bad. It's just what that means is that, beyond a normal pharmacy, we have this huge extra stack yet of regulations and guidelines and best practices that we need to adhere to. And I'm a rule follower. So especially, I can't speak for all compounding pharmacies out there. So I say, as a consumer, you really should walk in their door and see what it's about, make sure it's a good fit. But I can speak to what we do. And if you walked into our pharmacies, a few things you would see is that it is extremely over-the-top healthcare in the sense of pristinely clean. And especially in the world of COVID right now, we have these cleaning protocols that occur every 2 hours that are really intense. On top of that, you would see we have 2 separate compounding labs in each pharmacy. And those labs do different things. I mean, they do similar things in the sense of both make capsules, both make suspensions, both make ointments and topicals, but they work with different types of products in each one or medications. So one is considered non-NIOSH, and NIOSH is this group that makes these lists of drugs. And so that one, we wear certain protective PPE, they call it, personalized protective equipment. And then in our NIOSH lab, which is the most controlled lab, we wear different personal protective equipment. So we literally look like we're going to space when you come in and look in these labs and see us because we are being safe. We're protecting our staff, we're protecting the product we make, and we're following the guidelines of what's been put in front of us. On top of that, yes, we use glass mortars and pestles, that traditional piece of equipment that most people would correlate with what is compounding. But we also work with extremely sophisticated equipment. What that does for us is improves our quality and our consistency from prescription to prescription, person to person, medication to medication. So say, for instance, I believe I'm the only pharmacy in Washington State. We actually use 3D print technology to custom compound our troches, which are like lozenges, and our suppositories. I have a FlakTech mixer that basically does what the mortar and pestle action does, but so much more complete and efficient and faster than that. So it's this speed mixer that does this gravitational rotation to mix powders and ointments and creams. It's super cool. And a bunch of other really neat technology pieces too that are, very precise and take a lot of training to be able to work with.
I'm just going to tell you, for all the years we've known each other, we've never had this conversation. And so I see the products that come out, but I have not thought about the technicalities and the toys that are behind the Oz curtain. And how many how common are compounding pharmacies? If you are a listener out there and you've never heard of a compounding pharmacy, what's the likelihood that there's one in your backyard?
They are all over the nation and even the world, even at that. But within the United States, I would say in any given state, you would likely be able to find a small handful. It could end up in some states being a couple. In our particular location, there's, I would say a half a dozen to a dozen. Mm-hmm. What I would consider, high quality compounding pharmacies that aren't what we call in the industry backbenchers. Okay. And backbenchers are people who they have a pharmacy, but on that back counter where they count your pills and everything else, they throw things together and they call it compounding. That's not compounding in my book at all. That's backbenching, and that really shouldn't be occurring if it is any longer. It's not been a standard of practice for a long time now. Typically, patients may have to look a little harder to find a compounding pharmacy, but they should be there. They should be in their area.
Is there a place that we can refer folks to find is there a national association that people can get more information about what's local?
Yeah. So you mentioned it in my bio, actually, and they just recently changed their name. So I need to update my bio. But it was called International Academy of Compounding Pharmacists. They've changed their name to Alliance for Pharmacy Compounding. And I can talk more about why they did that in a minute. But their website is the letter A, the number 4, and then the letters PNC.com. So A4PC, Alliance for Compounding Pharmacy. They do have a search tool there to help consumers find compounding pharmacies. They are advocacy lobbying group, which we know we need a lot of that support in compounding world because we're a small fish sometimes in a big stream. Another place where consumers can go to find or locate a compounding pharmacy is the PCCA, which is Professional Compounding Centers of America. They also have a search tool and they have a way of helping consumers link to pharmacies in their area that would be good choices for helping them.
And Kusler's and Clark's both ship, is that right? You're obviously anywhere in Washington State we can order, you can ship meds. But how many other states in the country do you ship to?
Clark's Compounding Pharmacy, my Bellevue location, we're licensed in 9 states currently. So obviously Washington and then sort of the surrounding states around that. So Idaho, Oregon, Arizona, and then it reaches out from there to other states as well. People could definitely always call us and inquire or email and ask, hey, do you ship to my state? We're happy to help with that. And we do a pretty good job too of working with doctors and helping direct prescriptions, if we're able to help or not. And same for even finding pharmacies. We do occasionally have people who move and they move far, far away. And sometimes we're not able to service them, but we also can help with a referral basis on that too.
So now that I feel like we've got a good understanding of a peek behind the curtain, let's talk about what is actually patient-facing. My experience when I call you guys is often something along the lines of either I know what I want to order, or I call you and say, I need something like this that does something like this, or I need something without this ingredient in it, because I think that that's one of the components that we don't think about with commercialized pharmaceuticals. They often have what's called excipients or vehicles that people, especially sensitive individuals like with mast cell activation or other allergies, won't tolerate. So let's start just kind of running through what are the things that you would get that would be unique at a compounding pharmacy.
The overwhelming theme is compounding pharmacies provide personalized medication. And so kind of a little slogan is we make the medication fit the patient and whatever that patient need is. So it's always solving a medication problem, whatever that problem might be. And so it could be things like what you were mentioning, like maybe somebody who's extremely gluten intolerant or corn allergies or all these other sensitivities. And those are often fillers or binders in commercial products. So the medication might actually make the patient more sick and using what's made by the big drug companies that are out there. So sometimes it's doing that sort of thing of just making a clean medication that a patient can tolerate, that specific patient can tolerate. And we do that a lot. I've got several patients where we literally custom compound every single medication they need just to make sure we take control of what fillers, binders, colors, preservatives are in that product to make it so they don't react to it. So that's one scenario. Another scenario is that it might be something that's not even being manufactured by a drug company. And low-dose naltrexone, I know that's one that you love fondly as well, but that's a great example of that because low-dose naltrexone is a medication commonly used for inflammatory autoimmune disorders, but it's not manufactured by a drug company at all. And actually, because there's no possibility of a drug manufacturer being able to attain a patent on that medication because it's such an old school drug, they don't see any dollar signs to find any financial positive factor on why they would ever want to commercially manufacture that. So that'll likely only ever be available through a compounding pharmacy. And then there's things that just combinations that don't exist. Like you and I do this a lot with sinus medications, where you might be able to call a retail pharmacy and they might have one ingredient in a nasal spray, but we can really look at the patient specifically, and maybe they need an antibiotic and an antifungal and something for biofilms, and put that all together specific to what their cultures and sensitivity reports say would be best therapy for them. They're really great because the patient experience is so good too. It's like we really make a difference.
With the first one you were talking about, like to process it without excipients, you can even do regular things like gabapentin or antihistamines like Zyrtec or Claritin. What are some of the other common drugs that you make that without excipients?
Yeah, so there's rules to the game, of course. Of course, we have to have a valid reason for why we would make something that might be deemed commercially available by a drug company, right? Because I can't infringe on their patent. That's patent infringement, and that gets you in really big trouble. So we have to have a for sure need, like patient tried and failed and it didn't work out. And then also along that, we have to be able to get that medication in its raw, purified powder form. So if it's not available that way, there's nothing I can really do about it, because I can't take the grody tablet they already made that the patient reacted to and crush it up and do something to it, because it's still going to have all that excipient in it. So there are some limitations in that aspect of, I need to be able to not infringe on a patent. I need to be able to source the medication in its purified form that has a good certificate of analysis that shows that, yes, it is pure and it's not, some contaminated thing that says it is what it isn't. And then we have to have a really good understanding of what can the patient tolerate. Like, is there a filler that this patient is okay with that we can use to be able to make it in that capsule form? Or sometimes we run into, nope, they can't do that. Or maybe they can't swallow pills. And then we need to know what type of liquid could we put it into that then they could drop their dose off of it that way.
Let's talk about some of the uncommon medications that I've been really interested as of late, including ketamine and oxytocin. Talk to us about those medications.
Ketamine, it's an old school drug. It's been around forever and what is commonly used in pediatric for, surgical situations in an IV form. And the reason it's so fabulous for that is that it's short acting and has a really good safety profile and is very well known to help control pain and can help control nerves as well. So an old school medication that actually compounding pharmacists have been working with that drug for decades as well and doing different dosage forms with it. Usually a nasal spray or a sublingual troche, which is like a lozenge you dissolve in your mouth, are the most common, or topical cream too, are the most common ways it's prescribed in compounding. Mostly because we can't go oral with that medication. It's what they call highly metabolized, which means when it goes to the stomach and goes to the liver chews the whole thing up and spits out nothing left. And so patients don't get a good effect from oral ketamine. So we have to bypass that, what they call first pass effect, and get it into the body a different way, which nasal, submucosal in the mouth, or transdermal on the skin where, say, there's an injury or there's neuropathy or pain going on, are the best ways to accomplish that.
Are there commercial preparations of ketamine?
Yeah, so like I mentioned, the IV preparation, of course, for surgical situations. There is a nasal spray that's recently come to market. It's different than what compounding has been doing, and that's a good product. It's got really very specific prescribing rules with it. And it's been brought to market with an FDA approval of treating post-traumatic stress disorder and refractory depression, these really big time psychosis situations for patients. And it's administered primarily in an office setting because they basically dose it so high that you want them to go almost to euphoria and super, super drowsy, because with those conditions, you're essentially doing a rewiring or a reset of the brain wiring to help break that cycle of the PTSD and the refractory depression and things like that. There's great potential. And I think that, it has a long track record. So that's nice.
And it's not a sedative in the same way that opiates are. So it is in the anesthetic class. Is that correct?
Yeah, it is not an opiate at all. It is an anesthetic.
And then talk to us about oxytocin.
Yeah, oxytocin's got the nickname of the cuddle drug, which, may or may not happen all the time for patients, but sometimes they are hoping for that. But oxytocin is a natural hormone that we create, that we make in our bodies. And it's generally highest in levels in nursing moms after they've delivered babies. And it helps with that bonding aspect of a new child. And so there's been a lot of interest around, well, what if we use that hormone and give it to other patients that aren't, new breastfeeding mamas? And would that help mental capacity? Would that help relationships? Would that help with intimacy and mood? And so we've been working with that quite a bit. Also, again, it's another medication, kind of like ketamine, where we don't go oral with it because it does nothing in an oral form. So usually in that, it would be either a nasal spray, which is great because it gets it right up to that blood-brain barrier and gets it into the brain really well. And then we have some patients who they're trying to extend how long it lasts. So they'll do like a sublingual lozenge with it or a troche. And that seems to work better for those need a longer action, need a more maintenance dose where maybe they're using it every day or 2 to 3 times per day to help with that elevated mood and that relaxation component, versus the nasal spray can be more of, oh my gosh, I'm getting into a really bad funk right now and I need to come out of it, or I'm having some major libido issues and I need help with connection. And it helps to get people out of that flight or fright mode of run, which is what our society has built, and get them back into a place of rest and relax and connection.
I am so interested in oxytocin. I know it is very short acting, and we've talked about this on the show before, this crisis of connection. And certainly COVID is both amplified, I think, and re-engineered how we connect. Obviously, you and I are on a Zoom call right now. We're not even, we can't sit in the same room and do this. Or if we sit in the same room, we have masks on and et cetera. So I think connection really holds some keys for making us remember how we evolutionarily developed to be together. And so I have a lot of hopes around oxytocin kind of reminding us of that. And if we can have that feeling, if we can kind of like jump to that lily pad in our mind, I think that we can then make that happen in our life. Yeah. So interesting. And there's no commercial products for oxytocin. Is that right?
No, there's not. And it comes back to, and this is the same with all bioidentical hormones or hormones that bodies produce, is the rules of the government state that you cannot get a patent on something that's found in nature. And so oxytocin is definitely found in nature, as are the other, bioidentical hormones that we compound for menopause. And so those are things that cannot be patented and then mass produced for drug companies to make.
If you are curious or interested about oxytocin, you need to find your compounding pharmacy and find a prescriber in your area. And then let's go on to other hormones, because this kind of brings up the hormone question. And hormones are a big topic. It's what I send a lot of prescriptions. I don't even think about them as much anymore because they're not as creative as the skin preparations we'll talk about. The hormones, I've been doing it now so long with you guys. But we should talk about them because they're a huge proportion of at least the prescriptions that I send. So talk to us a little bit about why, hormones are available commercially. So what's the difference?
You're right. There are hormones out there and you can get them in a retail pharmacy, but most of those are not considered bioidentical. Most of those are considered synthetic. And it goes back to that patent thing of, drug companies can't take and patent, say, we'll just pick on, estradiol. It's not as easy to get a patent on that. And they typically need to change something about the molecule to make it so it's more patentable. So when this first started, drug companies came out with things like Premarin, Prempro, and these were synthetic estrogens and synthetic estrogen progestin to try to help with hot flash symptoms. And that particular one is derived from pregnant horse mare urine, marin. And they literally, collect the urine, get the estrogens out of it, make this product. And in that, though, it's different than what we as humans make, because it contains about 50 different estrogens, because horse estrogens are different than human estrogens. So with compounding pharmacies, we don't deal with those types of hormones at all. We only deal with the bioidentical hormones, which are the hormones that the human body would make on its own. And we're only putting back to the level of what it would have been before menopause. And if you think about that, it's a whole new journey for us, because the age of death rate was way, way lower, not very many decades ago. That our lifespan, was that, you would live till, 50s or maybe 60, and that was considered old. And now with our lifespan, we go clear into the 80s very easily. And we don't have as much history on, how do we live that second half of our life essentially with lack of producing hormones on our own? Because our hormone production was sort of like, you make your hormones, you procreate, and then you're done. And there's no reason to continue living. Well, we know that that's not where we're at. And we'd like to keep going longer than that. So we needed to figure out, how do we do that? And that's why treatments for menopause and andropause for men became so important. So we can keep that longevity, because without the hormones, the brain declines, the bones decline, everything declines, and we have a pretty low quality of life often. So that's the hormones we work with. So when we compound with them, they're all customized based on what that patient needs. There's no just, here's your one cookie cutter hormone, it's going to fix everybody. It's super individualized. Yes. And it's usually combinations of using estrogens in very specific ratios and progesterone, and sometimes even testosterone, even for women, to get those levels just right.
Yeah. And those levels can be a moving target.
Definitely so. And we're seeing it with COVID, where I feel like that's the never ending day-to-day conversation I'm having, has to do with, now we're in constant fight or flight that's not ending, that's been going on for months now. And whether people are feeling really stressed or scared is not always the issue, because your body can feed on that, whether you mentally think you're okay or not. And what it's doing is your adrenal gland is making more and more cortisol to make sure that you can maintain life. And when it begins to decline in that cortisol production, it'll start stealing the sex hormones, specifically progesterone, to make sure it can make enough cortisol. And then we have women who are on hormone replacement that last year were doing great, that now all of a sudden are feeling like super hormone deficient again. We redialed, but you're right, it's constant moving target based on age and stress and diet and environment and everything else.
What I often say in clinic is that when we think about it, if we get our periods, if we have menarche, we start our cycles around the ages of between 11 and 14. By the time we're 15, we've all been having our periods. Some women are later, but by the time we're 30, we could be grandparents. By the time we're 45, we could be great grandparents. And by the time we're 60, we can be great great grandparents. And we should just be sitting around, hanging out with our pals, bossing people around, and kind of having a chill life, watching babies, being with our friends and family. And so I think evolutionarily speaking, by the time we're into our 50s and 60s, Ayurveda, which for one has been compounding for millennia, they looked at doing these nanoparticle dosings of metals. They did that thousands of years ago, which is kind of fascinating. And they set the human lifespan between 100 and 120 years. The fact that our lives no longer can support us in our 50s and 60s, we are still very active. We are still running companies. Many of us still have young children or are rearing children. And many of us are alone, which is part of the issue for the oxytocin. Many of us do not have the support of a community, so that we are those women, especially, who are trying to do it all, where we wake up, we get our children ready, then we work all day, then we come home, then we're cooking, then we're trying to be with our kids, then we're trying to clean up, then we're trying to set up for the next day, then we're trying to wash all the clothes, then we're trying to clean up so there is so much work to be done, so little support, and we're really in a kind of a pickle.
Definitely. And when I was doing retail pharmacy, that's exactly where I called it the trifecta of prescriptions. And it would often happen to that 30, 40-year-old lovely mom wearing a billion hats and doing it all. And it starts out with they go to the doctor because they're feeling really blue and their family just doesn't understand why they're so blue. And they get the antidepressant. And then all of a sudden it's like, well, I'm having these anxieties. So they get an anti-anxiety medication. They're not sleeping. So they get something for insomnia. It's like this. We saw it time and time again of these busy working moms overtaxed that were starting to get into the time period of hormone decline that Western medicine just doesn't do a great job with them at all. When really what they needed was, let's look at your overall hormone health and, oh my gosh, your progesterone level is declining. Well, progesterone is the hormone that for ladies helps us rest, relax, sleep better, natural diuretic. It's our calming hormone. So of course, at that age in her life, with everything else she had going on, she was starting to have all these other symptoms that were actually probably mostly hormone related.
And we talked to you about that when your ovaries start to go to sleep a little bit as you reach this perimenopausal time, your adrenals have to kind of pick up the baton, and that sometimes they can't do that if they've been so taxed. And so then you get spurts and failures, and that's where we get menopausal symptoms. And menopause, remember, just for our listeners out there, menopause is technically 12 months, no period. If you've had a hysterectomy in your 30s or 40s, before you were into menopause, you may not know when your menopause is actually happening, but it's technically that 12 months. So anytime between when your periods start to get shorter, lighter, heavier, more abnormal, the rhythm changes, that until 12 months after your final cycle, that is your perimenopausal time. Can you talk to us a little bit about the difference between topical and oral progesterone, especially for sleep?
Most of the time with the other hormones, so say estrogens and testosterones, you'll only ever hear me recommending topical or possibly sublingual dosage forms. And that has to do with safety things. But with progesterone, I really like to look at the individual person. And one of the questions I'll always try to delve into is, how is their sleep? And if I'm getting any wavering of, sleep's not great, or they're having to take, melatonin or other things to help support sleep, or it's broken, or they're feeling exhausted and not well rested, I'll often recommend oral progesterone. And it has to do with, I want that first pass metabolism. I want it to go to the stomach. I want it to go to the liver, because the body is magic. It'll convert the progesterone into 16-alpha hydroxyprogesterone, which actually causes drowsiness. Mm-hmm. And so sort of I guess you would call it side effect, but I don't know that I would call it a side effect. But another effect of oral progesterone is an enhancement for better, more sound sleep. Now, it doesn't mean they take an oral pill of progesterone and 10 minutes later, they're knocked out like they would be with a sleeping pill. It's that over time, looking back reflective, they'll find they're actually sleeping better and more soundly and feeling more well rested the next day. But it's not magic. I always tell my hormone women that be patient. You didn't run out of hormones in a day, and we're not going to get you back there in a day. And part of it is not only just putting the hormone back into the body, but it's getting all those receptors to remember what to do with that hormone. And so it's usually weeks to months of consistent, well-managed treatment that we start having aha moments of, yep, we're on the right track. We're trending in a better direction now.
For testosterone and estrogens, you can do them. So sublingual drops, I know I've prescribed through you before, but then also topical creams. So topical creams can go on. Where do you put them on your body?
They're usually made in a very elegant cream base. We actually use a cream base that's been specifically designed for delivering hormones, and it is considered hypoallergenic. So even our most sensitive patients, most of the time, do very, very well with topical hormone replacement of estrogens and testosterones. I try to make it simple for patients. So this is what I tell them. The rule of thumb is you're looking for thin skin, good blood flow, not a lot of hair follicles. And so every woman's body type and composition is different also. And especially if I'm counseling by phone, I don't get to see what this patient looks like. And some thoughts on that are, if they are by chance a heavier set person, it doesn't mean they can't put it on the heavier set portion of their body. It just might be slow to get circulating within their body. So 2 places that any body type person can definitely use for a rotating site would be inner wrist or behind the knees. Other places are inner forearm, inner thigh. And then we do have a lot of prescribers that really find great benefit in having patients provide or apply their hormones to outer vaginal labia. And if you think about it, it's that super thin mucosal tissue that's going to suck hormones up, no problem. But if I ever have a patient who maybe is not too sure about that for a site of application, I kind of give them a free pass and go, look, you can do inner thigh, you can do behind your knees, you can do inner forearm, all are great. I do usually also tell women to think about if they have a lot of close contact with other people. So inner forearm, summertime, and taking care of children is probably not a great site because there would be a possible chance of transfer risk to another person. COVID has kind of fixed a lot of that. We're not really touching most people anymore, even sometimes our close family. But if we have that situation, that inner thigh or behind the knees takes care of that completely also.
How long would a person after application need to avoid contact?
So it's not been fully studied. So say, for instance, it's estrogens and they have a small male child that they care for. I'm over the top conservative and I really don't want exposure to that site, probably mostly at all. Let's say though we have, grandparents age, they don't really have kids around most of the time. We would say great application, which means rub it in until the cream's all the way rubbed in and then massage the area for an additional minute helps to increase the blood flow and helps draw the hormones into the body. Washing their hands afterwards, we would generally recommend no swimming, bathing, super close contact for a good couple hours after that application. But I kind of give that disclaimer in there because every patient scenario can be so specific. And so we're always happy to talk with those individual women on, tell me what your life looks like. Do you have grandkids around? Do you care for other people? Do you sleep with pajamas on or not? And then help guide with best application sites for them specifically.
Sometimes we'll use bioidentical hormones around the vagina just for incontinence or for dryness. So those may or may not be focused on a systemic application.
Yeah. Often in that case, it might even be, different hormones used. So a different estrogen, or it can be even lower doses. But yeah.
Like estriol, like E3.
Estriol. Sometimes estradiol though, but just in usually a lower dose. But there's super good evidence on a link between increased risk of bladder infections and women who have low estrogen levels. And so, we see this a lot too in retail pharmacy of that sweet little lady in a nursing home setting who's getting constant urinary tract infections all the time. And one of the things that could be helpful for her for treatment of a prevention modality would to be having her use some sort of vaginal estrogen product to keep that tissue in much greater health aspect.
One question about progesterone is how young can you use progesterone?
Progesterone typically is a hormone that'll decline in production about age 30. So as we're moving into that perimenopausal phase, I would say I super, super rarely see it in younger than that. But it's typically with a whole lot more thoughtfulness around it because sometimes, and this can even be true for women in their 30s, sometimes when we start fixing this hormone imbalance, we start putting hormones back in that weren't there before that needed to be there, we can actually make a female more fertile. So we usually need to really make sure we're having conversations around that and we have some plans in place on, do they want to conceive a child? Do they have a partner? Do they need to think about some method of contraception to prevent that? If we sort of as a, not intentionally, but in managing their hormone balances happen to make them more fertile. So I likely don't see hormones generally much at all used in teens and early 20s because of this possible increased fertility thing. And maybe there's some other mental stuff, family thing going on that maybe the child isn't being fully forthcoming on their sexual activity. And it's just a little bit more risk than often we want to take. That doesn't mean we don't do it. There are specific cases where I have seen it. And especially if we have, some major depression going on and we've got super major cycle issues going on that weren't able to be controlled by maybe herbal supplementation and dietary control and these other lifestyle sorts of solutions. I've definitely seen it just not as common.
Can you talk to us about if you have a uterus, you'll need to be targeting estrogens as well as progesterone. You don't want to do unopposed estrogen, correct?
Yes, that's very correct. We definitely know that unopposed estrogen can, in some women, increase risks of inadvertent consequences that we wouldn't want. So in adding the progesterone to that, it's extremely well documented that we can better balance that estrogen and mitigate a lot of those risks. It doesn't mean it's risk-free. It just means that we have less rate of risk of, say, cancers of the cervix and the uterus and things of that nature, breast cancer, possible relation with unopposed estrogen and effects on clotting and heart. So we do need to be kind of conscientious. And that's another reason actually why we only ever do estrogens topically is we now have good evidence that topical estrogens don't change clotting risk. But we do know oral estrogens increase risk of clots for sure. And when we're talking clots in this case, our biggest concern is stroke. We don't want to have a patient have a stroke because of oral estrogen. But we do know that in topical estrogen, we don't have that risk. So that's really important. The other thing women can control that actually increase risk of clots severely is smoking. So smoking has a huge correlation, especially over the age of 50, of increasing risk of clots. So ladies out there, you want to lower your risk of stroke and clotting. Don't smoke, don't start, don't ever, think about it. And if you do smoke now, find ways to stop because it could literally save your life. So that's one of the things there with that risk. So even if a woman has had a hysterectomy, it's still probably a really good idea to use progesterone with the estrogen because progesterone has receptors in other places in the body besides just the uterus. So there's other good reasons to make sure we're always doing the estrogens and progesterones together in tandem and getting that balanced out right. I like to give patients that analogy of a teeter-totter where you have estrogen on one end and progesterone on the other. And we know if the one estrogen end goes up too high, you don't feel good there either. And if the estrogen's too low, you don't feel good either. You really want it balanced in the middle. You want them well weighted just so they're balancing each other.
Any other thoughts that we should share about estrogen, progesterone, testosterone?
The important thing is just to make sure that as a patient or as a consumer, you're working with a provider that really understands hormones and is working with bioidentical or the more natural hormones that are more like your body and is able to follow you. It's not always the best answer to go in and pressure a doctor who maybe isn't very well versed in that. Just say, hey, I need hormones and I want them this way, because you won't have that monitoring piece, that follow-up piece. And there's a lot to it. And Jillian, I'm sure you do a great job of this, but it's not just subjective of tell me patient what's going on. That's part of it. But there's, very specific lab work that can be done to help make sure the hormones are being metabolized appropriately, that teeter-totter balance is right. And so it's really important that patients have a really good team behind them of a prescriber who's knowledgeable in hormones and a pharmacist that knows them very, very well and can help answer questions and help be part of that team.
Let's switch gears. There's two other things I want to get to before we close today. One is topicals, because this is what I have had so much fun with you guys making topicals for pain, for shingles, for anti-aging, for eczema. So talk to us a little bit about the different bases and some of the different things, psoriasis, rosacea. What are the things that you treat that are topical and what kind of stuff do you put in there?
So as far as conditions, you totally hit the nail on the head. That's a really good list of the most common things that we're helping take care of with topical prescription medication combinations. And based on what's going on is where we bring in our science brains and help develop those perfect formulas. So say, for instance, is it topical or do we need transdermal, which means it has some driving power to get it a little deeper? Usually if we're doing dermatology sorts of things, anti-aging, psoriasis, eczema, dermatitis, those are usually topical. And we're typically choosing bases to put medications in that help promote healing. We have a base that helps prevent scarring. We have a base that helps with the psoriasis and eczema, getting the inflammation down and putting the healing nutrients back into that really inflamed skin. So that's that aspect. Oh, and then for cosmetology, I love our biopeptide base. That's actually what I personally use and have custom formulated ingredients put into that base. And that's what I've used as my daily moisturizer for probably about a decade now. And so that's a little bit different than, say, the other aspect of we're dealing with pain or shingles. We usually need a bit more driving. And with pain, we may really have to delve deep into how far do we need to drive that medication into the body, get it in where we want it. So in that case, we're using a lipophilic, so likes lipids, transdermal base. It's the one we prefer to use is lipoderm because it has the best evidence behind it from studies of getting drugs in where we want it. And it's pleasant for patients and things like that as well. So two different things, but let's just start with pain and shingles. And so we picked that cream base. We've got that lipophilic driving cream base. And from there, we can very specifically, sort of from like a menu, so to speak, pick which medications make the best sense and then custom tailor how strong or weak they are for that patient. One example that we do a lot is a combination that has anti-inflammatory, muscle relaxant, and anesthetic agent in it as well. So we'll use things like diclofenac and baclofen and cyclobenzaprine and tetracaine. And we're, in this case, working really hard. That would be a great neuropathy formulation. Also would be helpful for probably more chronic muscle spasm to help quiet the location down. But we can fine tune that. We can put things like ketamine into that if they need something more powerful for neuropathy, or amitriptyline is another great anti-neuropathy medication. Or if we have a patient who's got a lot of renal involvement, maybe we don't put an anti-inflammatory in there because those are metabolized through the kidneys. Maybe we pull that out and just stick with, other methods. Can even put magnesium in it to help get muscles to calm down too. So that's one aspect.
And we've even talked about doing low-dose naltrexone topical.
Definitely have. So low-dose naltrexone's got some evidence. Granted, they're, small patient case studies primarily because, as I mentioned, there's not a big drug company wanting to patent it. So there's not any multi-million-dollar drug studies happening. But in patients with psoriasis and eczema, I've had some really great successful cases on putting naltrexone into a topical cream base, usually the Zematop base that's designed for the eczema and psoriasis skin. And then in with that, we could even pair in other things too. If it's really itchy, we can put something in to calm the itch. Like ketotifen is a great option for that. It's an antihistamine with a mast cell stabilization aspect. And then if we need to feed the skin more, we can put some zinc in. We can put some cyanocobalamin, which is a B vitamin that's been shown that usually psoriatic lesions are deficient in B vitamins. So we can put that food back into that. And then usually they apply that to that affected area 2 to 3 times a day. And on follow-up, usually at about 6 weeks is roughly where I like follow-up for any sort of derm condition, because we want that cell turnover cycle, but we can have some really positive movement in a great direction of healing in those lesions.
I've really had so much fun over the years, like calling you guys and being like, okay, so this is the patient, this is their specifics, this is what I'm targeting, this is what I think they'll be able to use. And it just is really exciting about the potential for customization. When we talk about personalizing medicine as the wave of the future, we still don't as much talk about personalizing their pharmaceuticals. And this is the way to do it.
Absolutely. And I agree with you that some of the best interactions I've had with patients are and you and I have had this specifically, you'll call me and give me that patient case, and I'll kind of get the feel from the prescriber's aspect of what the therapeutic goal is and what challenges I might be facing against. And then you allow me to reach out to that patient and sort of start guiding and getting some buy-in and understanding better what their barriers to therapy are. Like, what is it that they think is going to make this impossible or possible? And from my perspective, between the two of you, you give me my parameter of I need to work within these boundaries to create something that will meet both of your goals. Because you as a provider, you want that therapeutic benefit. You want the patient to be able to stay compliant with them. You want them to get better. And then from the patient aspect, I want them to live their best life. And if I can play a little role in that on how we accomplish that, it's a win. it's a big win for all of us.
Let's talk about one other major class, one other major grouping of medications, which are all the sinus medications. As you and I were talking before, there's actually some new research just coming out about ME/CFS, chronic fatigue syndrome, and looking at the microbiome in the sinus cavity and the connection between how close it's just that little cribriform plate that separates the nasal cavity from the brain. So there's things that we can do in the nose that impact neuroinflammation directly. And Ayurveda has a long history of Brahmi ghee and eucalyptus and camphor and sesame oil and nasya. There was a whole class of medications called nasya, which is basically nasal application. That's all that means. And so one of the things that we do at Center for Healing Neurology is MARCONS testing, so multiple antibiotic resistant coag negative staph. And we can do a swab and look at the biofilms and look to see if there's this MARCONS, which can impact melanocyte stimulating hormone production, which is a major anti-inflammatory support for the body. So if our MSH is low because our biofilms are disturbed, then that also may persist inflammation. So when we're talking about medications we can stick up the nose, what are our different groupings? What can you guys cook up for us?
This is definitely becoming the wave of the future on how to handle chronically ill patients. And these aren't patients that are going, oh, I have a sinus infection. Usually they're like, no, I breathe fine. My nose is good. I don't have anything going on. But like you mentioned, they've got this overall encompassing inflammatory condition that's affecting every part of their body. And yes, it's probably stemming from what it's doing in the brain.
Or if you ask them, they'll say like, well, I've got that postnasal drip, but I've had that my whole life. So there's a symptom that they have kind of acknowledged, but it's become so much a part of their identity, they don't even think about it anymore.
Nope. Or a cough. A cough is another one. Like, oh yeah, I've always got a tickle. Or my nose drips. My nose drips all the time. It's like, you're right. We just deal, right? We're like, oh, it's fine. I'm not that. I feel pretty good. No fever, no green snot. So therefore I don't have a sinus infection, right? Well, that's the misnomer of it is not only do you have a sinus infection, you've probably had it for extremely long time. And especially in the Pacific Northwest, and you'll probably agree with this, that there's no pathogen that's not possible for when we're culturing it because we're so moist so much of the year, right? That we get high levels of mold infection. We get high levels of bacterial infection because they love the environment. And sometimes our houses that we're living in have these infections in them and we don't even know it. We don't see the black on the wall. We don't have this weird funky smell. Like until it's really delved into the shell of the house, you don't even know you're living in a sick environment or with sick air filtration until decades later and you've got this massive illness and inflammatory condition and all that. So sinus compounding is evolving as we speak, and I'm really, really excited with where it's going. And I've been a sinus compounding expert for almost 20 years now. I started out doing some really creative stuff with an MD up in Everett, 15, 20 years ago, when he started seeing these chronic mold infections. And he's like, here's what I think's going on. And we had a lot of fun of coming up with the best formula that worked most of the time for his patients. And it was in a liquid nasal spray. And I did a bunch of testing on it. And he was doing case reports. And we knew it worked when he called me one day and said, I've made all the surgeons really, really mad because they're not getting near as many referrals from me because I'm making my patients better. We are winning. So do I have experience in that? Yes, I sure do. But we're getting more savvy about it because our biggest struggle that we've always had with compounding nasal sprays is the need to put pretty sensitive medicine into a water environment that's then sprayed up into the sinuses, because that's how you did a nasal spray, right? But the problem is over time, most of those sensitive medications don't maintain their viability for very long. Like there was one medicine we were working with that we were lucky if we could get 2 weeks potency out of it, and then it would just crash and burn. And it's like, why bother? Now you're giving subtherapeutic dosing. It's not working anyway. So what we're doing primarily now, especially when we have a provider such as yourself that does these great tests, is we can customize what medication is in it. So questions we ask are, do they need an antibiotic? Yes or no? And if so, which one? Do they need something to break up biofilms? Do they need an antifungal? And do they need a steroid short-term to help reduce the inflammation so you can actually get the medication in the sinus you want to get it in? It's kind of like our 5 paramount questions that we go through with each individual patient case to build it. From there, what we've learned is nasal sprays aren't very effective at delivering medication into the sinus cavities that we want them to hit. They're very topical in the sense of they spray right on the nose piece that you and I see on people, right? They don't go into those deep sinuses that are below the eyes or up into the forehead, where a lot of times patients are carrying these extremely chronic infections. So we've learned that irrigation is probably a better delivery method if possible. And there's a little bit of debate on which way is the best way to deliver it. And part of this comes down to patient acceptability as well. There's, of course, the, neti pot or those squishy, I call them squishy bottle, irrigation bottle things that patients can do. And that's likely better than a nasal spray for sure. But it still probably doesn't get as deep in there as we would like unless they've got this super amazing technique of knowing how to position their head just right and suck it up in there and get it back out and all that. We also work a lot with, there's actually a device out there called a sinus nebulizer. That works even better. And they've done some studies on this, and actually they claim 30% better penetration with a sinus nebulizer versus traditional irrigation devices. And so I still think it has a bit to do with technique because, you got to use the nebulizer right too. And I also think sometimes patients are so raw and inflamed in their sinuses that maybe they can't even start on that sinus nebulizer. They've got to start with a squishy bottle or the irrigation system before they can go to something that's going to get better penetration. That's my experience. So what we do is we take this customized, I'll call it cocktail or menu of medications that we've selected for that patient specifically. And in our compounding pharmacy, we actually compound them into capsules. And then we use a filler in it called loxosperse and xylophos. And that filler also has therapeutic action because it contains xylitol, which you and I know very well. Xylitol is a natural sugar that's actually been found to be antibacterial. Actually makes the medication more pleasant too, because it's got a little bit of a sweet aftertaste to it. And then it also has an ingredient called pluronic in it. And what the pluronic does is it helps to increase contact time of the medications to that mucosal membrane of the sinus cavity. So instead of just irrigate, oh, here it comes and it's out, and now you've got to wait, anywhere from 8 to 12 hours before you do that again and you're not being treated, it'll actually hold some of that medication against that tissue. So you're getting a longer treatment time with it. So we use that to make the capsules. And then what happens is the patient opens the capsules, mix it in with their sterile water for irrigation, and only ever sterilized water. Never, ever, ever tap water. You will give yourself the worst infection you've ever seen. So sterilized water, they swirl that for 30 seconds, and then they use that to irrigate. So now we have a product that's shelf stable, may need to be refrigerated depending on the ingredients we pick, that then patients can just take, open, mix with their water at the time of using, and we don't have to worry about the decline or the degradation of, is the antibiotic still effective? Is there still antifungal in it? Did it all get killed off because it's been in this water environment? So that's kind of how it's been working with the sinus world, and it's been really successful.
Yes. And your nebulizer, you have, there is squishy bottle or people can use it neti pot style, but you also have something that when I first started prescribing it, the patient came back and said, it was so shocking. I pulled it out of my nose and it shot like 6 feet in the air.
This nasal irrigation device, I always recommend patients just stick some of your saline water in it the first time and just in your shower or your bathtub, just turn it on and look at it because you kind of got it. It's super simple. It's not like it's hard, but because, it's got a little motor and you push the start button, you hear the motor, it kind of makes you jump and then you feel it. And so it's sort of nice for them not to waste their dose that first time and just put some sterile water in it, turn it on, kind of feel it, see what it's about, and then you're ready to go. It's like, I always tell them, it's like once or twice of just doing that, you're going to be a pro in no time flat. This is not hard. It's just different. And so they just got to get used to it.
And I think it really does deliver that medication in, which is exactly what we want.
For sure.
And there's other things that we can nebulize as well, like glutathione, or do essentially deliver via the nose.
We've got a lot of leeway on what we want to get in there. Typically, it's looking at bacterial treatment, rebuilding tissue, reducing inflammation, And glutathione's a good example of that because that's exactly what it does. It's a free radical scavenger, and it helps to get bad things out of the body, helps to get the inflammation down in the body so that it can rebuild. And there's some good evidence in doing that to improve immune system in general. One thing I wanted to point out, when you and I are talking nebulizer, I'm specific for sinus nebulization because a lot of times we think lungs, right? Because that's a traditional pharmaceutical. We have asthma, we need a lung treatment, we use a nebulizer device, but that's different. And actually, based on laws and guidelines, those types of nebulized products have to be made in a sterile environment as if you were making an injectable to be injected in the body versus sinus. Because of where it's being delivered and how it's being delivered, that's something that we work with specifically.
We have covered a very broad spectrum of pharmaceuticals and compounding, and I feel like we have barely scratched the surface, but I hope folks today are taking home a few conclusions. Number one, that compounding pharmacies exist, that they're very modern, that they've got fancy ways that you're concocting personalized medications, and that they do exist and they can find them. The second thing is that it's a way to get medications without all the excipients and fillers that might actually be making a person sicker. And that for the medications that you're taking, if you want to check out if your local compounding pharmacy can make that, or if you want to contact Clark's or Kusler's, those are options. And the third thing is that when we're looking at really specific treatments like in the sinuses, on the skin, and especially with bioidentical hormones, that compounding pharmacies have some really unique offerings. And the fourth thing that I hope folks take away is that you are awesome. Dawn, you are awesome. Like you just, what you know, you are clearly so passionate about this, and that we can see that you're putting this into practice every day you go to work, and that the pharmacists that you have at your shops are going to just be top notch. And that's been my experience with you clinically over the last number of long years, and just kind of reinforced with this conversation today. So I'm really, when I said in the beginning, we're blessed to have you talk to us today, it was not said lightly. I really appreciate all your expertise and your willingness to share it. Thank you.
Oh, absolutely. Well, thank you so much for having me. It's a mutual respect your direction as well, that I feel blessed to be surrounded by amazing, providers like yourself that do such a good job for their patients.
Anything else you want to add?
Yeah, I think that's it. I'm always welcome to have patients, whether they're my patient or not. If they need any information, they're always welcome to reach out to us. So Clark's Pharmacy in Bellevue, Washington, or Kusler's Compounding Pharmacy in Snohomish, Washington. And like you mentioned, all of my pharmacists are amazing. They are all top notch. They're all doctorates of pharmacy. And we're actually, being that we're teaching sites, we always have super, super smart, very well researched PharmD candidates working in our pharmacies too. And they love research questions. So we're always here for you.
All right. Well, thank you everybody for listening today with Dr. Dawn Ipsen, because you have a doctorate of pharmacy. We've got lots of ways to continue this conversation through Facebook, Instagram, and Twitter. And you can also get more information from and about us on our website, centerforhealingneurology.com, or about Dawn's pharmacies at Clark's Compounding Pharmacy and Kusler's Compounding Pharmacy. Be sure to share this show with your friends. We welcome your rating and review wherever you get your podcasts, and feel free to send topic requests to podcast@centerforhealingneurology.com. We love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together, and we're committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. Thank you for listening, and we'll see you all next time. Thank you, Dawn.
Fish Media. Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org or realrentduwamish.org.